Squamous cell carcinoma accounts for more than 90% of oral malignancies. It's 11th most common cancer in males and 16th most common cancer in the females. The oral cavity is lined with stratified squamous epithelium. The first variety is the keratinized stratified squamous epithelium, where the squamous cells produce a layer of keratin. The oral surfaces that are lined with the stratified keratinized form are the hard palate, gingiva, and dorsum of the tongue. The second type is the non-keratinized type. Here the cells produce little to no keratin, and the surfaces that are lined by this type are the lateral and ventral surface of tongue, floor of mouth, buccal and labial mucosa, soft palate, and the retromolar trigone. Among risk factors, tobacco smoking is the single most important cause, along with use of smokeless tobacco like snuff and use of betel quid or pan. Second most important cause is alcohol consumption, which has an additive effect when combined with tobacco smoking. Other factors are radiation exposure, oncogenic viruses, immunodeficiency, nutritional deficiency, and the oncogenes and tumor suppressor genes. Oral epithelium may undergo various pre-malignant pathological changes before progressing to squamous cell carcinoma. First one being leukoplakia, which is a white patch. Now this whole thing starts off with a thin and smooth form, which can progress to a thick and fissured form, and later on to a granular verruciform variety. All these three have chances to go back to normal epithelium only if the causative factors are removed. However, if the causative factors still remain in the life of the affected person, this can eventually progress to a proliferative verrucous leukoplakia variety. Now, proliferative verrucous leukoplakia is the most severe form of leukoplakia and has 4 to 8% chance of transformation to squamous cell carcinoma. As the damage progresses further, clinically red patches start to appear, and we observe erythroleukoplakia variety. As the cells have been damaged more, they produce lesser amount of keratin, and hence we observe white and red patches. This situation may progress later to erythroplakia, where the cells have started to produce little to no keratin. All these three varieties have a high malignant transformation, and the chances of conversion to squamous cell carcinoma have increased highly. Squamous cell carcinoma could present as an exophytic type, that is mass-forming, papillary, or a verruciform type. Endophytic is an ulcerated, invasive, or a burrowing type. Specifically for squamous cell carcinoma, the ulcer is centrally depressed, irregularly shaped with rolled everted borders. It may also present as a leukoplakic patch, that is a white patch, or an erythroleukoplakic patch that has a combination of red and white patches. And lastly, as erythroleukoplakia, that is red patch. The extraoral site affected by squamous cell carcinoma is the vermilion portion of lower lip. The risk factors include ultraviolet radiations from sun exposure, pipe, cigar, cigarette smoking, and reverse smoking. Squamous cell carcinoma of the lower lip may be of an exophytic type, that is verrucous in nature, or an endophytic type where there could be a chronic non-healing ulcer that is crusted and indurated. In case of a deep invasion, it may metastasize to submental lymph nodes. Most commonly affected intraoral site is the lateral border of tongue. It has a predilection for men in the 6th to 8th decade of life. Squamous cell carcinoma of the lateral border of tongue may present as an indurated, non-healing ulcer, an exophytic lesion, erythroplakia, leukoplakia, and a combination red and white lesion, that is erythroleukoplakia. There is a tendency for the squamous cell carcinoma from tongue to metastasize to submandibular lymph nodes and the jugulo-digastric lymph nodes. The second most common intraoral site is floor of mouth. Lesions of floor of mouth mostly present as patches of leukoplakia or erythroplakia. They have a tendency to metastasize to the submental and submandibular lymph nodes. Other intraoral sites that may be affected by squamous cell carcinoma include gingiva, buccal mucosa, hard palate, retromolar trigone, and the oropharynx. The histopathology of squamous cell carcinoma includes presence of islands and cords of malignant squamous cells. There is noticeable angiogenesis, which is formation of new blood vessels, desmoplasia, which is a dense fibrosis induced by tumor, and a strong inflammatory and immune response, all seen in the underlying connective tissue. Along with all the previously mentioned histological characteristics, what's specifically seen in a well-differentiated squamous cell carcinoma is that the island and cords of malignant cells are very much resembling the normal squamous cells, along with characteristic keratin pearl formation, which is seen in the diagram over here. Just as the name suggests, the cells present in the islands and cords of this variety of squamous cell carcinoma have lost a bit of resemblance to normal squamous cells and have become moderately differentiated. And there is little to no keratin formation in this variety. While in poorly differentiated squamous cell carcinoma, the cells have lost most of their resemblance and are termed poorly differentiated. There is no keratin formation in this type. As for the definitive diagnosis, any non-healing indurated ulcer with roll-diverted borders that has persisted for more than 3 weeks needs evaluation. Thus, an incisional biopsy of the lesion is a definitive diagnosis. The treatment options available for squamous cell carcinoma are surgical removal of the lesion if local mets have not taken place, or surgical removal of the lesion along with neck node dissection if metastasis to lymph nodes has taken place. If carcinoma has spread to distant organs and is unresectable, then chemotherapy and radiotherapy are used to eliminate the cancerous cells and prevent further spread or the recurrence. Chemotherapy and radiotherapy may be used in combination or along with surgery based on the treatment plan and spread of the cancer. Prevention of cancer is much important and requires timely intervention, hence removal of harmful noxious stimuli and seeking of professional help as soon as any suspicious lesion is seen that may be aggressive, persistent in growth, or continuously growing is important to save you from losing an important organ functionality and even your life.